So this is a cat spay with autoligation. This cat has already been draped. This is the cranial aspect of the cat. This is the caudal aspect of the cat. You see when we've draped, we have the umbilicus. It's just peeking out from underneath the drape. I then have the cranial edge of the pubis. So I'm feeling for where the pubis falls off into the abdomen. It's very important to make sure you have the cranial edge and not the caudal edge because it'll put you in a completely different area. We have the cranial edge and the umbilicus, and in a pediatric cat, I'm going to go and make my incision right in the middle between those two, and it just so happens that the edge of this drape also happens to be the cranial edge of the pubis. Now, before we start, we're going to do three things to make sure that we're ready to go. The first is to count our swabs, and I have 1, 2, 3, 4, 5 swabs. Second thing is I'm going to ask my anesthetist, are you ready for me to start? Anesthetist gives me a nod. And the third thing is a deep breath. So we're going to take a deep breath, hold it in for 4 seconds, and slowly exhale it. That activates your parasympathetic system and your vagus nerves and relaxes the surgeon as much as it does everyone else around you. I'm going to go umbilicus, cranial edge of the pubis. I'm going to go right in the middle. I'm going to tent my skin, and I'm going to make a little incision. A bold incisions. I'm going to press a little bit harder than most students would. I don't need a very big incision in little cats, especially if I'm doing autoligation. And you can see I have the fat just peeking out from this incision. I'm then going to use my mosquito hemostats, and I'm going to put them with the mosquito side down. I'm going to go in, and I'm going to boldly expand it. So what I'm trying to do is I'm ripping that fat apart. I'm going to go caudally, in the middle, and cranially. You can see I'm starting to have that linea alba poking through. I still have some fat around it. I don't like removing fat because what that does is creates dead space when you close the animal up. But I do like doing is grabbing some rat tooth forceps, grabbing the fat along with my Metzenbaum scissors, and I'm just expanding that a bit more, and I'm matching up my fat incision to my skin incision. But what I'm not doing is I'm not removing any of that fat. And that just tucks under, and you can see a really, really nice linea alba right there, peeking through. Next thing I'm going to do is take my other forceps, and here we have dressing forceps, tissue forceps, along with the rat tooths. I'm going to try to grab that linea alba with the rat tooths, quickly grab it with my tissue forceps, and I'm going to walk it up cranially. You don't want to go too far, because if you go too far, you're actually going to go underneath the skin. Just enough where I feel I've got a good exposure. I'm going to grab my blade. I'm going to go a bit lower down across the linea alba. I'm going to go in at a 90-degree angle to the linea alba. I'm going to need to go through the linea alba and with the peritoneum underneath, and I'm going to extend that up, down, up a little bit until I get to the top. Right. And I have my incision, and I'm going to get my non-traumatic, non-rat tooth dressing forceps. I'm going to close them. I'm holding them in the non-traditional pencil grip, but the palm grip. I'm putting them in caudally first, opening them up, and lifting up and away. And I can see I can extend that incision a tiny bit, and then I'm going to swap my hands, and close, go in, and here I don't need to extend cranially at all because I'm already under the skin as it is. Next decision is to whether you're going to get the ovarian horns and start fishing from the right side or the left side. I'm standing on the right side as a right-handed surgeon, so this is the right side of the animal, this is the left side of the animal. The right side is more cranial, so it's more difficult to get. So some students will like to go off to the left side to make it easier on them. The left side does have the spleen, so you have to be careful. It's very easy to poke a hole in the spleen or hook the spleen when you're lifting up the ovarian, the uterine horn. I personally like doing the right side. The right side is nice because you get the hard one out of the way, and then you have the easy one going forward. There's a little bit of fat poking through this abdominal wall, and you can see there's also a little bit of fluid. Pediatric patients do have a bit of fluid, so just make sure you don't confuse that with the bladder. Sometimes you're worried that did I poke the bladder when I opened up the animal, but that's usually just pediatric fluid, serosal peritoneal fluid. What I'm going to do is then go underneath with my spay hook just to lift that rectus sheath of that linea alba. I'm going to go ahead and grab that right in the middle, so I have a nice opening. 4 things to do when you're fishing out the uterine horn. You're going to point that hook towards yourself If you are on the doing it on this side, on the opposite side, you're going to point it away from you. The point is that you want to point it into the gutter of the animal, and you're going to go down into the gutter. That's number one. Number two is we're going to flip it 180 degrees. That's going to face it towards the viscera and towards the horn. We're going to sweep, and then we're going to pull up. And right there is exactly what I'm looking for. When fishing for the ovaries and for the uterine horn, it's important that when you go down into the gutter and then flip, sweep up and pull up, that the sweeping up and the pull up are two distinct actions. What you don't want to do is as you're sweeping up, as you're sweeping pull up, because you're going to go right over the uterine horn. Now that we've found the uterine horn, we can take a look at our anatomy. This is the broad ligament. The broad ligament is this big sheet ligament going across through the uterine horn. You can see behind us, there's this little white line, and if I can reach it from here and grab it, that's going to be our round ligament. So this is our round ligament, which we're going to cut later on. But right now, what we're going to do is grab our uterine horn. We're going to feed it cranially. So I'm just feeding little by little until I get a nice white little ligament. This ligament here, that's your proper ligament. So the proper ligament is a ligament between the uterine horn and the actual ovary. And then if I feed that a little bit more and push that down, I've got my suspensory ligament right here, and that suspends the ovary from the ovary to the body wall at the level of the cranial pole of the kidney. What I'm then going to do is I'm going to get some kind of instrument. Now you can use your fingers to do this. You can use an instrument. These are the vessels. I'm going to make sure all the vessels are in my left hand. I'm going to poke through. I'm going to go up and down. I'm just going to make this hole nice and big. Now, the vessels at this point are very close to the suspensory ligament, and I can't actually separate them. But if you go caudally, you can see how that opens up. So that suspensory ligament and the vessels kind of come across away from each other. With autoligation, I'm going to break my suspensory ligament because I want a little bit more exposure, and I also don't want to include the suspensory ligament in the autoligation of the ovary. When doing autoligation is absolutely appropriate for both pediatric cats as well as adult cats. If the vessels were very big, let's say I was doing a pregnant spay, that's probably a time where I wouldn't do an autoligation, but for the majority of them, you can go ahead and do them. What I'm going to do is pull caudally. I'm going to open up that gap between my suspensory ligament and my vessels, and I'm going to put my blade right in between, push through to the other side, and then I'm going to flip it cranially, and I've cut off my suspensory ligament. Now, there's two ways of doing it. The first way I'm going to do it is the way I teach students to do it, just because it mimics that of a cat castrate. So I'm going to put my ovary, pretend this was a testicle. So if you're going to hold a testicle in a cat castrate, you'll be holding it the same way. And I'm going to get my mosquito hemostats. I'm going to face them pointing down towards the inside of the animal. I'm going to go over the vessel underneath. I'm going to flip around. As I'm flipping, I'm opening, and I'm putting that vessel into my opening so that I'm just at the tip, but I have it fully grasped, and I'm clamping down. I'm then going to go ahead and take my blade. I'm going to cut off that vessel really close to the clamp, making sure that I don't go ahead and cut off the knot. Now, unlike a castrate where the testicle is off, this ovary is still connected to the vascular blood supply. So I'm going to grab another hemostat. I'm going to clamp it right across the proper ligament and push that off to the side. The next step that I need to do is remove the tied off vessel to form into a knot. I usually point the hemostats down. I don't flip them because that puts in another hook into them. I'm going to point down and I'm going to push that off. Now you can push it off with your fingers or you can use a swab. It doesn't really matter. I usually try pushing off my fingers, and you can see I can see the metal or the body of the hemostats on this side and on this side. A little bit I need to come off. I know that knot is down now, and the important part here is pushing it further down. I'm pushing the knot. I'm not pulling underneath it. And you can see how far away that knot has gone in. And then going to grasp that very gently at the edge with my forceps. I'm going to unclamp. I can see that it's not bleeding. I'm going to put that into the body wall, and then I'm going to let go. Now, you don't have that much exposure of the tissue at this point, so I probably could get to the bifurcation, but you can see that round ligament is fighting me. And so what I'm going to do is I'm going to take this uterine horn, pull it cranially. You can see how that round ligament is going to open up. I'm going to hold the vessels with my left hand. I'm going to make a small hole. You don't want to make a big hole because that'll rip into your vessels and start bleeding. I'm just making a small hole. I'm using 4 fingers to break that ligament. You can see that round ligament is usually quite rubbery and it's difficult to break. Once you break it, you'll have really nice exposure. I'm pulling down and away. I'm not pulling up because I'm not going to be able to get it. Down and away. You can see that bifurcation coming out. I'm going to go ahead and grab the next uterine horn. And I'm going to follow it up cranially. Same anatomy. There's my round ligament peeking out. It's actually on the other side this time. So this is kind of a mirror image of what we had on the other side. There's our proper ligament. And there's our vasculature. You can see this is a really good way of showing how that opens up. I'm going to use my fingers this time. There's a little bit of momentum on the other side. I'm going to push down. Okay. I'm going to use my fingers. I'm going to make a hole in that broad ligament with my fingers. And down. Right. What I'm now going to do is I'm going to push that caudally. And you can see it opens up my suspensory ligament for my vessels. I'm going to go in with my blade through to the other side, put it cranially and cut. There we go. Now, there's 2 ways of doing this. We can go ahead and do it the same way we did the other side. Put it towards us and grab it like we would a cat castrate and do the typical instrument tie. Or what we can do is keep it that same way. This is the same exact thing. You're just doing it from opposite sides. I'm holding my hemostats as I would an arrow. I'm putting them to the left side or cranial, and then I'm just going underneath and around. And I find this side easier. It's a bit more difficult to learn if you haven't been doing this and have been doing cat castrate. And then I just clamp that. And to me, this is much easier just because I have a better visual of it, but it has to take a little bit of practice to get that correct aspect going. What we'll then do is I'm going to cut, and I'm not going to cut high, I'm going to cut nice and low, but away from that knot to make sure I don't grab that knot. Remember that we do have the blood supply still attached, which is why it's bleeding a little bit. I'm going to put a clamp right on the proper ligament, push it off to the side, and we're going to push that inwards down towards the cat and pull it off. I'm going to use the swab for this. That is a beautiful knot, making sure that's nice and tightened, and I am super happy with that. I don't need to check that for bleeding. I'm going to go into the animal, let it go. Now we have our uterine horn. You'll notice the difference in exposure, even though it's the right side, which is more cranial, so it should be actually shorter. That's due to that round ligament. So once again, pull that forward, round ligament opens, small hole, break, and now you can see you have very good exposure, and we have more than we need in terms of the uterine bifurcation. This is where we're going to actually start using our suture. We're using a 3-knot polydiaxonone, which is PDS suture. It does have a lot of memory. It's a monofilament. It's big enough for the cats. What we're going to do is we're going to do modified Millers, and there's a few ways of doing modified Millers. Whenever we're suturing, we're always putting needle holders underneath tissue, grabbing the suture, and pulling it forwards. Now, if I was doing just a square knot, I'd be going around once over my fingers, going through, and that would be a square knot and a regular circumferential suture. But because we're doing a modified Millers, we're going to make this a little bit longer. We're going to go underneath again, grab that second piece of suture, go over our finger, and what I'm going to end up with is a double loop, and that little tag hanging through, I'm going to go through both loops with my needle holders. I'm going to grab that loop, clamp down, and pull it through. That's all there is to it. Now with a modified Millers, I know I've got the holding power of a surgeon's, but the smoothness and the occlusion of a square. I don't have the bifurcation, so what I'm going to do is I'm going to put my needle holders down. I'm going to grab my pinky, and I'm going to use my pinky to grasp the horns, pull it cranially, so I can see I'm way below the bifurcation, and then use these two fingers to tighten that. And so I'm tightening right below that bifurcation, trying to make as small the tail as I could. And I'm pulling quite hard, hard enough to tighten and get nice blanching, but not hard enough to rip it. I'm quite happy that I'm below the bifurcation. And then what I'm going to do is put about 5 or 6 more loops on top of that. Remember, when we're suturing, we're not flipping these needle holders. We're keeping them steady. We're just going around, grabbing, pulling nice and relaxed one more time. Okay, it's my suture that does all the work. Just like that, and I'm just using my needle holders to grasp and pull. And that lets you go nice and fast because you're not using the needle holders to flip around. And I'm going to put at least 6 on there. I probably have more than that because I already lost count. And then on my last one, I'm nice and relaxed, so I always get square knots. If you pull hard, you'll get a slip knot. You see how that changes into a slip knot? Just relax it down to make sure it's a square knot. I'm going to put both of those in one hand if I can. Got Mayo Hagar's needle holder, so I don't have scissors built in. And I'm going to leave about 3 millimeters on either side, and I'm quite happy that that's going to hold really, really well. Next thing I'm going to do is get 2 sets of clamps. Now you notice we didn't clamp the uterus because in cats it can be very, very friable, and we don't want to clamp and have it fall off into the abdomen. In a dog I would be clamping, so I'm going to be clamping now at this point. There's 2 vessels. There is a left and right uterine vessel. You can see past here, little red parts. What I'm going to do is I'm going to go right above that ligature, and I'm going to clamp just 1 vessel. So you see that 1 vessel is clamped, the second one isn't clamped, and then I'm going to go above that, and I'm going to clamp all the way across. What I'm going to do is take my scalpel blade. I'm going to go from the bottom up, so I'm always cutting away from the animal. I'm just going to cut close to my top clamp to get rid of everything. I'm going to move that off to the side, and you can see because I'm holding just 1 vessel, the other vessel is not held, and there's a little bit of blood that was trapped between the ligature and the actual end of the vessel. So I'm checking for bleeding as we speak. I don't have to go grab my forceps and check that way. I'm happy that it's not bleeding. I know that both vessels are held by that 1 ligature. So if 1 vessel isn't bleeding, the other vessel is not going to be bleeding as well. If I were to let go, this would probably get stuck onto the skin. So I'm going to put it into the abdomen with my hemostats and just let go, and that should disappear down. There we go. Perfect. Things to do once you're done. This is a nice fast spay because of the autoligation. I don't have too big of a hole. I probably could do a smaller hole. It's a pediatric animal. Counter swabs, and I can see I have 1, 2, 3, 4, 5. I'm counting off camera. And now we can go ahead and close. When we're closing the body wall. The body wall is the rectus abdominis muscle. The rectus abdominis muscle has a fascia, and that's exactly what you're closing, not the actual muscle itself. I have my needle loaded. I'm always going to suture as a right-handed surgeon from right to left, but just remember that you're always suturing towards your forceps. That's the key. What I'm going to do is I'm going to try to find the edge. And you can see, go ahead and adjust my needle, find that edge again. That white part right there is the rectus sheath, and that's muscle. So I'm going to go close to almost past the end. I'm going to get a small bite. You see, I'm not going full thickness. Even in this small cat, I'm just grabbing the rectus sheath, pulling it up, and I'm going to go onto the opposite side. Grab that as well. I'm holding my needle. I'm not using my fingers, I'm using forceps to hold it, and then I'm just dragging that through little by little. I'm not dragging with one motion so I don't go off camera really nice and high and desterilize my suture. Into my V, around just a single square knot. We don't need surgeons. Unlike the past knot that we were doing on the uterine horn, this is just appositional. I just want to put it down until both pieces come together. There's nothing that we want to occlude. We don't want to cause pain by having any muscle fibers that you did detach or any nerves getting cinched down and cause pain. And once again, into your V, nice and relaxed. My suture's doing all the work, and I'm going nice and relaxed. Back and forth. 3, 4, 5. I'm going to start off with 6 throws. The reason being is these throws are everything that's going to hold the entire simple continuous suture. And then I'm going to close with about a 2 to 3 millimeter end. And then we continue on. Simple continuous. Making sure we don't touch the needle. This is a cutting needle. It can make very small holes in your gloves, which can desterilize the cat. I'm using my pinky just to lift out. And I'm grabbing with my forceps, letting go. And I'm going underneath through one side, not full thickness. Off to the other side. The important part here is I'm grabbing with my forceps, pushing nice and hard with my forceps, letting go, unclamping, reclamping, and so I'm ready to go. And we continue that over and over until we finish a spay. Partial thickness, just making sure I get the rectus sheath. Now, it's very easy in some animals. She has a really, really good delineation between her rectus abdominis muscle and her external rectus sheath. Some animals don't. In dogs, you shouldn't have much of an issue because it's very visible, so there's no excuse for going full thickness. If you have a very small cat that doesn't have much of a difference between one and the other, then by all means, go full thickness. I'd rather you go full thickness and make sure you have what you're looking for in your bite rather than not. Now, at this point, I'm just checking to see if there's any more of an opening. I can barely get my forceps in. So what I'm going to then do is just go full thickness through both. Once I'm lifting up away from the organs. And I've got a loop. The loop now becomes my short end. Into the V, around, still nice and relaxed. I'm grabbing, pulling through. And then as I pull through, I am opening my needle holders. And the idea of opening my needle holders is so I get a nice equilibration of both sets of part of the loop. Into my V, around, grab, pull, open. And see, you can see it right there. That one end got pulled more than the other. And now by pulling that, it slides the other end through as well. That's 2, 3, 4, 5, 6, and we'll do 7. So one more than when we started, just because it is a loop. That first one doesn't count really well. And what we're then going to do is use scissors to cut that off completely. You can tie your skin to a tag left here, but these are actually 2 separate layers. You can see they move quite independently of each other. And so if you do that, you will get a bit of a pucker, which I don't really like too much. It's also good to learn how to do a full buried suture. Next thing we do is we're doing the intradermal layer. The intradermal layer is going to close the skin. This is a really, really small incision. Probably say it's about maybe a centimeter and a half. Because of that, we're not going to close the 3rd layer or the subcutaneous layer. If this was a bitch spay, or if it was a big incision because there were fetuses or a C-section to remove, then I would absolutely close my 2nd layer, close the sub-Q. But in this case, we're just going to go straight into dermals. There's really not going to be much of a dead space here. Now, what we want to do is we want to bury this anchoring suture. So when we bury suture, we go deep, superficial, superficial, deep, as opposed to superficial, deep, deep, superficial. So I'm going to grab a little bit of the fat. Now, in order to close the sub-Q a little bit, instead of anchoring at the end, I'm going to anchor it kind of in the middle. I'm going to grab that fat out. Okay, I want to put all the fat out, and I want a big bite. I don't want to come out close to the dermis. This is just an anchoring suture, right? But I do want to make sure that I have a good bite of that subcutaneous layer that's below the fat. Gonna pull that through. Then I'm going to go off to the other side, find my fat, pull that fat out, get a really good bite. I want to make sure that both my ends are facing cranially. So they're both facing inside and downwards. You don't want one end facing the other way because then you'll be tying over your loop. Once we're happy with that, same thing. We're going to do 6 throws just because this is the anchoring knot for your entire row. 1, 2, 3, 4, 5, and if I can get that 6th one going, it doesn't want to go. 6. And then cut off the one tag. Now that is a buried knot. but it is still peeking up. So what I'm going to do is hold my needle at the tip. I'm holding it at the end, actually. That's close to the swage down area, but not at the swage down area. I'm going to pull up my needle. I'm going to go underneath and behind it with the intention of coming out right at that split of my skin, right in that dermal layer. That's a bit close to the skin. There you go. I want to come out right into the dermal layer of my incision. What that's going to do, reload my needle, I'm ready to go. Just going to pull that knot underneath like that. It's going to come out and start us right where we need to. And because we made our anchoring knot not at the bottom but more in the middle, you can see it's closing our sub-Q as well, which is really fun. Cool. Next thing we do is we go our intradermal. There's two things that you need to remember when doing intradermal sutures. The first thing is wherever you hold and however you hold this skin, your needle follows the skin in a parallel layer. I want that needle to always be parallel, right? So it's always parallel to the skin. The other thing is, this really cool contraption called a wrist. Use your wrist to drive the needle with your tip down. Go forward. So what I like starting out from opposite the side that I started. It doesn't really matter. You can start close to you. What we're going to do is we're going to grab that skin, evert this skin, find our dermis. Now the dermis is really, really thin, especially in this tiny little kitten, so we don't want to go too far. I'm going to start almost at the end of that incision and go right into that dermis. There we go. And I know I'm in the dermis because it's going to be a little bit tighter than if I were in the sub-Q. The sub-Q is going to go through like butter. I'm going to pull that through. You can see that it's coming out a little bit more cranially. I'm going to go a little bit behind into the dermis, making sure I come out right at that dermis as well. Perfect. Grab, unclamp, reclamp, ready to go. And that should bring the incision together. And I'm just going to repeat that over and over again. Using my wrist, making sure it's parallel to my incision, going in, coming out into the dermis, unclamp, reclamp, pull through, evert it out, into the dermis, travel underneath a little bit, make sure I'm not coming out of the skin. There we go. Perfect. At this point, got very little to close, so I want to pre-plan my closure. You could go one more on the other side and then do your closure. I think I'm perfectly fine in what I have. What I now need to do is need to do a buried loop as well as a deep tag that I can tie off to. So going back and forth in my dermals. To make my deep loop, I'm going to now start going perpendicular to my skin. And I'm kind of going to go in the middle of what I'm left with. I'm going to extend that out, flip, using my wrist. I'm going to go into the dermis, since I'm going dermis deep. And you can either pull that out or just go straight in to deep, come out at the dermis. I'll make sure that I do have a good chunk of dermis in there. There we go. And I'm going to pull that up. Now, because I did everything in one fell swoop, my deep loop is actually going to be right here. That's my deep loop. So it's in between that deep dermis, deep dermis. And I have a loop that's going from deep on both sides. However, my tag, which is this one, is superficial. So at this point, I like weighing this down, getting this out of the way a little bit. And then I'm going to go back off to the other side. I'm going to grab my skin, evert it, and I'm going to go dermis deep. That's a very, very tight turn. So I just want to go through one side, not the other. Make sure you go on this side of the loop. So the loop that you've created is off to the opposite side, because you want to make sure that your deep tag, which is what I'm pulling through, is next to your deep loop. Now notice, I had just the right amount. One of the biggest mistakes that people do is that they do their intradermals too tight and they don't have a lot of room left over to actually do a fully buried loop as well as a buried tag. Same thing, loop, tag, V, both are coming from deep. Grab, pull, open up. And at this point, I want that suture to just disappear under that fat. See, I can no longer see that suture, but I don't want to pull it too hard where I accordion the whole entire thing. And then I'm going to do 2, 3, 4, 5. I'll do 6 on this. 7 is absolutely appropriate as well. Nice and tight. I'm going to cut off my loop. I'm going to cut it off probably about 1 millimeter or 2, really, really close, because I want to bury that. I'm going to reload my needle. Now, the important part is I'm going to use my fingers. There's no reason to use your forceps. I'm going to use my fingers. That knot is coming out in between 2 layers. It's coming out from the deep. I want to go right next to that knot. I don't want to get any tissue in my needle. I want to go right next to that knot. Come off to the side quite a bit. Pull through. Grab my forceps to grab my needle. Pull that needle through. Hold my suture end. And then I'm going to push down with my fingers. I'm going to pull that knot until I feel it pop. And then you can see that knot is absolutely gone. I'm going to cut nice and close. Get everything to the side. And then I'm going to take my drape off. And I'm going to check. There's my umbilicus. There's a cranial edge of the pubis. And you can see I was right in the middle. And I had really good exposure both cranially and caudally. I could have made that incision a little bit smaller. And that's an autoligation spay.